Okay, so this lecture is about autoantibodies, or any antibody that reacts against a self-antigen. What normally happens during T and B cell development is that when the T or the B cell is found to react against the person's own antigens, those would be selected against. As you remember, you have positive and negative selection. And that negative selection triggers apoptosis in those cells. And there are special cells called follicular T helper cells present, which usually help to remove those cells from the population. Apoptosis is triggered and they're eliminated before they fully mature. We also have a population of cells called suppressor T cells, which are present in the mature population, which help us to induce tolerance to self-antigen. Suppressor T cells inhibit B cell activity. Because remember, B cells can fine-tune, well, T cells can too, but B cells are known for their ability to fine-tune their sensitivity to a particular antigen. And that potentially could make it more reactive against a self-antigen. But the suppressor T cells help to reduce the overall activity, which should prevent that from happening for the most part. If you lose suppressor T cell activity function, we actually see an increase in patients who've lost suppressor T cell function. We see an increase in autoantibody production. So we know that there is definitely a correlation between that kind of activity of the suppressor T cell and B cell oversensitivity. Now, it's not really understood why exactly there would be failures, but there certainly are some associations that occur with autoantibodies and various infections and certain drugs. In those cases, you're seeing a situation where a foreign antigen resembles a self-antigen. So you can see where that might come into play. But in other situations where you have autoantibody production with no evidence of an infection or any evidence of a drug production a problem, then they're not really sure why failure occurs. The reality is probably it's a mathematical thing. You know, things fail. And so mathematically speaking, you're creating trillions of these T cells and B cells. It's possible that you one or two sneak by. Now, the major problem with autoantibodies for us, in particular in the blood bank, is that autoantibodies get in the way of our reactions. So when they're there, everything reacts. If everything is reacting, then we can't detect those alloantibodies that might be present along with them. Okay. Now you still need to know what the autoantibody is directed against, because you already know that the person is reacting against their own, let's say, JKA. Let's say they make an auto JKA. They're going to react against their own. Why would we give them more of that antigen to enhance that reaction? So we need to give them units that are separate, that are negative, and that will increase the survival of the cells, which is the whole purpose of the transfusion. Now, in some cases, you don't necessarily need a positive DAT. Remember, DAT is where we test for sensitized cells. So a person with autoimmune disease against a red cell antigen, with a red cell antigen, would have a positive DAT. However, that's not the only way to diagnose autoimmune hemolytic anemia. Okay, there are other causes of hemolysis that aren't necessarily a part of autoimmune hemolytic anemia. So we need to be on the lookout for some of these other causes of these hemolytic anemic events that don't really have an immune mediated issue. Okay. So you've got, when you're trying to determine the causes of this hemolytic anemia that's occurring in your patient, first of all, you're going to determine, is it warm or is it cold? That helps you determine if it's an IgM, as you see in the picture. Is it the pentamer, or is it the monomer, the IgG? Okay, and then you're going to look at some other lab results to be able to determine what exactly is going on with this patient. Is this autoimmune hemolytic anemia, or are there other things going on? Now, again, with the DAT again, it's not going to be the end all. If you do DATs across your whole population, about 0.1% of perfectly normal blood donors and up to 15% of hospitalized patients, they're going to have positive DATs with absolutely no evidence of hemolytic anemia. Okay, so it doesn't necessarily mean if you have a positive DAT, you definitely have autoimmune disease. Okay, so but it's a good place to start, certainly. Okay, we have to establish, once we have the positive DAT and once we have evidence of hemolysis, we have to be able to establish that the destruction that's occurring is definitely caused by the immune system. And so the things that we're going to look at in the lab, the results that we're going to look at a reticulocyte site count. If we have hemolytic anemia, we're going to see an increased retic. If we have hemolytic anemia, we're going to see increased bilirubin, indirect bilirubin or unconjugated. We're going to see an increased LDH, which goes along with the destruction of the cells. And then we're going to see decreased haptoglobin, decreased hemoglobin, hematocrit, which go along with anemia. Okay. The decreased hemoglobin and hematocrit, you may think, are the first things you're going to see, but actually no, they're not usually. They're frequently the last things that we see, and that depends on whether or not your marrow can compensate for the hemolysis that's going on. Okay, so the patient might not actually have signs of anemia, but they might have signs of hemolysis. Okay, so making sure that we understand you can still have hemolytic event going on, but it might not quite be anemia yet. Okay, in uncompensated anemia, you're most likely going to see all of the signs, the decreased hemoglobin and hematocrit, and your smears are going to show the evidence of that decreased cell. If you're even in compensated anemia, where the bone marrow is churning out fresh new cells, you can look at the peripheral smear and you can see the effects of that. So remember, young cells are slightly larger than especially cells that maybe are just losing their nucleus or just have lost their nucleus. They'll be slightly larger, so you might have slight macrocytosis. And it's not uncommon for you to see spherocytosis in these cases also, because the cells take on the look of spherocytes because of damage that's occurring from the antibodies being produced. Okay, so the damage isn't necessarily sudden. It can build up, and that can cause spherocytosis. And then your retic count will be greater than 3%. That's one of the things that we look for to see if something's going on in our patient. Now we still need to screen for autoantibodies, and the DAT is going to be our easiest go-to test for this. Okay, that's the direct antiglobulin test, and what you're looking for here are cells that have antibodies bound to them. Okay, there are lots of autoantibodies that are able to sensitize red blood cells without causing lysis. So the DAT can be something, obviously if you have outright hemolysis, that's a pretty good sign too, but many of the autoantibodies will just sensitize the cells, so you need to be able to detect those. Okay. Now the positive DAT can be caused by either cold or warm autoantibodies. It can also be caused by certain drug interactions, as well as if it's an infant, you have to be concerned that it's HDN or potentially a delayed transfusion reaction. So you have to know the patient's history. Are they taking any one of the drugs that can cause a positive DAT? Have they recently received a transfusion, or is it an infant who was recently born? Those things might cause a positive DAT as well. You have to make sure to use an AHG, a specific AHG reagent. So you want to use one that's directed against IgG or C3, not both, because you want to narrow down the cause. Is the patient cell sensitized to antibody, or is it coated with complement? That you'd want to be able to figure out which is the cause of the positive DAT. Okay. Now, there is a little bit of a difference between the testing in tube testing and gel testing, the automated testing, and it's based on the sensitivity of the procedure. Okay. Now, normal individuals, they can have actually a small amount of IgG or complement on the surface of their red blood cells, and the studies have shown that there can be between 5 and 90 molecules of IgG per RBC, and between 5 and 500 molecules of complement per red cell. Okay. Now, if you do tube testing can detect usually between 100 and 500 molecules of IgG per red cell. So that's above the normal. And between 400 and 1100 molecules of complement at a minimum. Those are those minimums, okay? The normal amounts generally wouldn't be, you can see there's a slight overlap with complement, but it's very slight. So the normal amounts usually would not trigger a positive tube test, okay? However, the gel and the solid phase methods that are the automated methods that we use in the blood bank, those are much more sensitive, in particular to the IgG coated cells. And so you might find a greater number of patients who will test positive for DAT if you use the automated methods. Okay. Some hospitals have decided, you know what, we're not going to use the automated methods for DAT, we're going to do manual methods. That's up to the hospital. As long as you can back it up with a manual method, you're probably okay. And remember that you always have to have your auto control. That's your other means. You run that auto control. That's another means of testing for the presence of autoantibodies. And that you're going to use that anyway during an antibody screen. It's your internal control, where you incubate the patient's serum with the patient's cells. The cells have been washed and everything, and you incubate them together. And if you get agglutination, that's a sign of an autoantibody. Now, and you would need to remove that autoantibody and characterize it once it's discovered, whether it's discovered in a DAT or in the auto control, and you do that by elution. So this is just a procedure methodology. I'm sure you've already done these tests in lab. This is just the DAT as these are sensitized cells that you're drawing from your patient. If it is positive DAT, you just mix it with the AHG. If you get agglutination, you know you have sensitized cells. So the DAT is the direct Coombs test, okay, direct antiglobulin test. When you have, if you look here at this example of this panel, first of all, look down here at the auto control. You can see that it's positive, and you can see that it's positive at immediate spin. That means it's cold. That's a cold autoantibody. And the cold autoantibody happens at immediate spin, and it usually will disappear by AHG, which you can see is what happened here. Okay, so the cold autoantibodies, like in this example, you can see they're usually benign. They're only going to be pathological if they continue to react at 37 degrees. Okay, but if they only react at immediate spin, you are not room temperature, so it's not usually an issue. You also look at the titers. If they're particularly high titers, it's something that we definitely want to be aware of. If they are enhanced they're usually not very well enhanced, the cold reactive ones. The pathological ones can be enhanced. So these are the things you're looking for, the characteristics. And the only one that's clinically significant, you can see here, is the one that's pathological, where it's still reactive at room temperature, very high titer, enhanced by albumin, and that would be the anti-I, can be, the anti-big I, can be a problem. Now, the specific cold autoantibodies that you've already heard about as we went through the different antigens. Obviously, the anti-big I, that's a high frequency antigen. It's in almost all adults. So, but it does occur. Adults can produce an auto anti-I. In most cases, it's not a problem again. Then you have the anti-little I. Okay, these, remember, the little I antigen is expressed on infants at birth. But there are patients who are big I negative, right? They are homozygous recessive for the allele, and so they end up being called little I adults. They can produce an allo anti-I if they're sensitized. But in most cases, we don't see the auto anti-little I. It's very uncommon. And that's because little I is expressed really from birth all the way through, because remember, the little I is converted into the big I. So even adults have a small amount of little I. Anti-H, that can be found in certain individuals, and usually those ones that we find it in are A1 or A1B individuals, where we normally find the anti-H antibody. Remember, those are the two that have the least amount of H substance. So we can characterize those by reacting the plasma with group O cells or group A2 cells, since those have the largest amounts of H antigen on them. And you can see the difference in reaction, which will help point to an anti-H characterized autoantibody. And then your A1 have the weakest expression of H antigen. Okay. An anti-IH adult is, so this is an I adult who's also happens to be Bombay, and they can produce this weird anti-IH autoantibody. So it's obviously very rare, but it does have an interesting history. So you definitely need to know about that particular autoantibody. And those are the most common specific cold autoantibodies. Less common are some, pardon me, anti-PR, anti-GD, anti-CIDX, and anti-M. Those are less common produced cold autoantibodies, okay? But they do exist, so just be aware. But the reactivity against the four most common ones, the big I, little I, H, and IH, know those and the difference between them, okay? So which cells are they going to be most reactive with? Now, again, we're usually not worried about most cold autoantibodies. However, there are a few that we do have to worry about. And in some patients, you can get even cold antibodies causing hemolytic anemia, which can be anywhere from mild to severe. Okay. It can also be a chronic situation, or it can be, and it can be idiopathic, so no onset, reasons known, and it can be acute, and it can be transient. So there's all different situations that you have for this. So for example, a transient case of cold autoimmune hemolytic anemia could be associated with an infection like Mycoplasma pneumoniae or infectious mono. They might bring on a cold agglutinin disease, okay? And about 18% of these are transient. They are associated with these infections, Okay, so in the 3 cases that we have here listed, you can see we have idiopathic cold agglutinin, cold autoimmune hemolytic anemia. You have secondary cold autoimmune hemolytic anemia, and you have proximal cold hemoglobinuria. Hemoglobinuria. Okay. For idiopathic, you can see the onset is generally around the age of 50, so a little bit older. It's mostly directed against an anti-I specificity, and actually it says in for the idiopathic, where there's no known association, you can see that I'm sorry, that the I'm being distracted here. You can see that the the associations that this patient is going to have with the anti-I, since that the anti-big I, what they're usually going to see is pretty much a seasonal situation, a seasonal demonstration of symptoms. That's what I'm trying to say. So the patients, usually you have this anti-big I specificity. You do have rarely, less commonly, the anti-little I, and even less commonly than that, an anti-PR specificity, but almost always it'll be an anti-big I specificity. The patient's going to experience numbness of the extremities, blue tinge coming from reduced circulation to the hands, feet and ears, those extreme parts that become cold first, fingers in particular, toes, ears, nose, those things. And it's really the triggering, the exposure to the cold that causes the red cells to agglutinate. So the red cells pass through the capillaries in those extremities where it's colder, and the agglutination can occur in those areas. Okay, it is possible to experience hemoglobinuria if complement gets fixed when it moves towards the warmer parts of the body. So that is a possibility, and we know that that's something that occurs with proximal cold hemoglobinuria, where the antibody binds in the peripheral circulation, and then lysis occurs as the blood warms up again. You're going to see an increase in LDH levels because there's damage to the red cell. So as the damage increases, you're going to see LDH levels increasing. The key thing that we see with these cold agglutinin diseases is that the patient doesn't have fever, doesn't have chills. Renal insufficiency usually doesn't occur with the idiopathic or the secondary cold autoimmune hemolytic anemia. Those usually don't affect the kidneys. Proximal cold, however, you can get some renal insufficiency that can occur. Okay, the patient usually with idiopathic or secondary cold, they might display some weakness, some pallor. And you might see some weight loss, and those would be associated with chronic anemias, which you already know those are signs of chronic anemias. The key thing is that idiopathic and secondary, usually you can be fairly stable as long as you treat it right. Move to a warmer climate. Don't get cold. Okay. And as far as the secondary cold, autoimmune hemolytic anemia, those are usually associated with some kind of respiratory infection, as I previously stated, usually the mycoplasma or maybe an infectious mono, something like that. Those are usually limited to the extent of the infection. Once the infection wanes, then so will the symptoms. Okay, but the specificity is pretty much the same. Now, what are you going to find lab findings wise as far as the idiopathic and even the secondary cold? Well, you're going to find reticulocytosis, so an increase in your retic count. Your DAT is going to be positive. Okay. With the idiopathic, it really should be complement only. Okay, that you're seeing. So it'll be complement specific. The reagent that you use, the C3 specific. If you do a peripheral smear on these patients, you're going to see agglutinated red blood cells. You're going to see polychromasia, mild to moderate anisocytosis, as well as mild to moderate poikilocytosis. And the hemolysis that can occur, it doesn't usually rise to the level of you needing a transfusion. But if you do need if your patient does need a transfusion, you're going to have to perform a cold autoadsorption in order to perform a cross-match, because you remember that autoantibody is going to screw up all your results across the board. And it has anti-I specificity, so 98% of your units are going to be anti-I positive. Okay? So you do have to remove that in order to be able to do a cross match if you do need a transfusion. And then again with the secondary cold one, just to point out with that one, because it usually it's after an infection, usually have some kind of upper respiratory infection. The most common specificity of that is mycoplasma pneumonia. About 50% of patients who develop this transient cold autoimmune hemolytic anemia had some mycoplasma infection recently. Okay, and recently it could mean more than remember. The immune system takes a while to produce antibodies, so could be 2, 3, 4 weeks ago. Okay. So you don't currently have an infection, but as the infection wanes and the immune response drops, you'll end up reducing your symptoms. Then what you're talking about in the case of secondary cold autoimmune hemolytic anemia is molecular mimicry. So there are antigens on the mycoplasma that resemble I, and so you end up with an IgM that has an anti-I specificity. Okay. Now the exception to the cold agglutinin rule is proximal cold hemoglobin urea, or PCH. Okay. This is the least common type of AIHA, only about 1 to 2% incidence in the population. And this one, unlike the idiopathic and the secondary, where we normally see it in middle-aged people, we can actually see PCH in kids, and it would be associated frequently with some viral illnesses, like, for example, measles, mumps, chickenpox, infectious mono, even some flu-like syndromes. Okay, and what you get here, remember we talked about the Donath-Landsteiner test and the Donath-Landsteiner antibody. What you get is an antibody that has biphasic characteristics. So the IgM that binds to the red cell binds at cold temperatures. That's normal. However, once it reaches the warmer temperatures of the core of the body, it will fix complement and hemolysis will occur. Okay, it is an IgG, so it looks like an IgM as far as the fact that the agglutination is occurring at cold temperatures. It's just a weird IgG. It binds at cold temperatures, and then it causes fixation of complement at the warmer temperatures of the core of the body. Okay. The specificity of this is usually anti-P specificity. So patients who are P negative are at a higher risk of developing PCH. Okay. And to do the test, the Donath-Landsteiner test, I think we talked about this when we talked about the P antigen, is you collect fresh blood from the patient and you have to maintain it at 37 degrees and then separate it from the serum, because you don't want any reactions to occur as the blood cools down. you're going to separate the serum into 3 different test tubes. And you can see here where it's been separated into the A group, the B group, and the C group. Okay, and you have 3 test tubes within each of those groups. In all the tubes numbered 1 and 2 in each of the groups, so A1, A2, B1, B2, C1, C2, you're going to add, they all contain the patient serum, of course, and you're going to, I'm sorry, let me say this again so I get it right. So tubes 1 and 2 of each set are going to contain your patient serum, and tubes 2 and 3 of each set contain normal serum, which is your source of complement. That's your control. Okay, you're going to incubate the tubes, so you're going to add 2 bits of serum to each of them. You're going to incubate the tubes at the various temperatures with a population of group O cells that happen to be P positive. So you get one of your panel cells. You put some drops of those in the you take a P positive cell, you throw it in the tube, and then you incubate it at at various temperatures. Okay, and what you're going to see are in the case of the A cells, which would have been chilled, then warmed, and then you have your B cells and you have your C cells where they're chilled the whole time or they're warmed the whole time. You get this Donath-Landsteiner positive where you see hemolysis in the group where they were chilled and then warmed. Okay. Now, what is this going to look like clinically, the PCH? It's hemolysis, and it's occurring intravascularly. So you're going to get a sudden onset of fever. You're going to get the shaking and chills that we associate with hemolytic reactions, as well as abdominal cramps and back pain, again, associated with hemolytic reactions. In this case, you're going to see hemoglobin in the urine. You're going to see bilirubin increases depending on the severity. Okay, and your hemoglobin levels, remember it was all dumped out of the red cells, they can drop significantly, 4 to 5 grams per deciliter. You're going to see nucleated red cells, you're going to see retics, you're going to see all of those things trying to compensate for the anemia that's produced. Now, if we compare the PCH, again, usually occurs in kids with cold hemagglutinin disease. So we compare the two, right? So cold hemagglutinin disease includes both the idiopathic and the secondary. Both of them, though, have an anti-I specificity. Okay, so look at the difference here. Be able to tell the difference. This chart just sums it all up. Okay, so you can read through this at your leisure. Now, in this particular panel result, you can see we're starting with the warm autoantibody. So look at your autocontrol there. It is 2+ mixed field at the AHG phase. So we know that this is a warm autoantibody. Okay, and you can see it's across the board. You've got reactions across the board. There's only the one cell that is not reacting. Okay. Now, luckily, these warm autoantibodies are less common, because if they were common, there would be a lot more problems for us in the blood bank. Okay, a lot more clinical signs of anemia, hemolysis. You'd need more blood bank intervention, all that stuff. Okay. However, because warm autoimmune hemolytic anemia does lead to hemolysis, they are going to eventually come our way if they have this clinical syndrome. Now, the onset of warm autoimmune hemolytic anemia can be either insidious or suddenly. You can have sudden onset. It can be secondary to certain diseases, and you can see the list of diseases that are associated with the development of these. You can have some kind of RES neoplasm, or reticular endothelial system neoplasm. And those include things like chronic lymphocytic leukemia, Hodgkin's disease, non-Hodgkin's lymphoma, myelofibrosis, and myelodysplasic syndromes. Those are all associated with potential risk, increased risk in WAIHA. You can also have certain collagen diseases, lupus, rheumatoid arthritis. Those increase your risk. Those are also autoimmune diseases anyway. So other autoimmune diseases, unfortunately, they like to cause more problems. There are certain viral syndromes, infectious diseases, which can, you talk about molecular mimicry, and you can end up with WAIHA. Certain immunologic diseases, in particular ones that might be genetic. So, for example, a hypogammaglobulinemia, it's a genetic disorder. Dysglobulinemia, where you have a dysfunctional IgG, and certain other immune deficiencies. There are certain GI diseases which can lead to WAIHA, and those are again associated with infections that can occur and have molecular mimicry taking place. Carcinomas, in particular of the GI tract, can cause problems. Pregnancy and chronic renal failure are all associated with an increased risk of WAIHA. Now, what are the signs and symptoms? Well, hemolytic anemia, what are those signs and symptoms? Same thing, pallor, weakness, dizziness, potential difficulty breathing, jaundice, fever, and then your peripheral smear. What's that going to look like? You're going to have polychromasia, macrocytosis from all those young cells, reticulocytosis. Now, reticulocytosis sounds like it's definitely going to happen, but actually what happens with warm AHIA is that the patient's bone marrow can frequently become hypoplastic, and that's usually because of some underlying disease, whether it's a neoplasm or a immunologic disease, something like that. In those cases, you're not going to see reticulocytosis. So you have 50-50 shot of this actually being an issue, depending on what the cause behind the autoimmune disease is. Then you're also going to see nucleated red cells. You're going to see spherocytosis because of the damage to the membrane, and you're occasionally going to see red cell fragmentation from the lytic process. The other lab findings that you're going to have, bilirubin will usually be increased, in particular your unconjugated or indirect bilirubin. Your urinary urobilinogen is going to be increased because your overall the bilirubin process is increased, so your urinary urobilinogen will be increased. Decreased serum haptoglobin in severe cases. And if anemia is present, of course, you're going to have hemoglobin, decreased hematocrit. Hemoglobin can end up in your urine as well as free hemoglobin in the plasma, and increased LDH. Most cases of warm AHIA will have red cells that have been sensitized not just by IgG, but they'll also have complement-coded red cells. So you'll have dual specificity. Both will be present on the red cells. In other cases, rare cases, only about 13% is it strictly complement. And then in other rare cases, you'll also find bound IgA or bound IgM. Those are less than 3% of the cases where you'll find either one of those. Now, remember, you have the 4 subtypes of IgG, and the subtype that's causing the problem that will determine the amount of destruction. And the order that I have it there, 3, 1, 2, 4. The most destructive IgG in this autoimmune situation will be IgG3. That binds complement the best. Okay, IgG1 is the second most destructive, followed by IgG2 and then IgG4. And with IgG4, there's almost no red cell destruction Okay, so depending on the class of IgG that is directed, that is primarily a part of this immune response, that will determine how much destruction is occurring. Now, one of the good things that is associated with warm AHIH is that most of the destruction in most cases will be extravascular, so that's a good thing. If you and you can determine that, is there a chronic, is there in a severe case you'd have outright hemolysis present in the blood, those kind of things. But in most cases, most chronic cases of WAH-IHA, the destruction is extravascular, which will the liver and the spleen take care of it. So that's a good thing for our patients overall. Now, in dealing with warm AIHA, remember what we're looking for are these IgG antibodies. So they react best at the AHG phase. So that's or IAT, whichever you're used to noting it as. So now, as a rule, they usually won't directly agglutinate saline suspended red cells at 37. However, they may be able to activate complement. And so if you use an enzyme technique, you'll be able to enhance the complement activity, and you'll be able to see that earlier. Okay. As a general rule, these autoantibodies won't interfere with your ABO typing since they don't agglutinate at room temperature. So you should still be able to perform ABO typing at normally. They won't interfere. However, they frequently do react in the RH typing. So you have to make sure that your RH typing includes a control to, because in case a lot of these antibodies do have reactivity with RH antigens, and so you end up needing that control in order to verify that the testing was done properly. Okay. Sorry. Running the control is going to allow you to see if the proteins that are in the antisera, that your reagent that you use, which are put in there as enhancers, they're part of the antisera, if they're causing the agglutination of the autoantibody. Now, modern reagents only contain, they actually contain no more than 7% protein in order to reduce this problem so that you don't get any false RH typing with an autoimmune situation. You want to be able to identify your RH negative patients pretty easily. Okay. We also have, you can get monoclonal antisera, which have a very low incidence of false positives. It's not no false positives, but it's a very low incidence. So you still need to make sure that you run that control. Okay. And make sure that you're not getting autoagglutination, which could be due to an autoimmune specimen antibody. Okay, and then if you do know that you have an autoimmune situation present with the patient, and you think you're having trouble, in particular with the RH, what you can do is pre-treat the patient's cells, because remember they would already be coated with antibody, so you'd want to remove that, and before you actually do your ABO and your RH testing. So you would pre-treat those cells with EDTA and glycine acid, which is called EGA, it's a reagent, or with chloroquinine diphosphate, CDP. Either one of those reagents would help you to remove the IgG from the red cells, and then you'd spin out the the serum with the IgG in it and wash it off that now removed antibody, and you'd have hopefully red cells that don't react anymore. If the treated cells then are negative, you can use them to do weak D testing as well as other testing to be sure that your RH results are valid. But again, make sure your control is there. Always run your control. Okay. Now your DAT is going to be expected to be positive in warm autoimmune disease. Okay, that certainly makes sense. It wouldn't be positive if the antibody species is an IgA or an IgM, right? Because our reagent is an anti-IgG, right? So that would be one of the ways that we would be able to classify the type of autoantibody. So if your DAT is negative, but your autocontrol is positive, ooh, that's suspicious, right? The other thing is when you do a DAT, and if it's an IgA or an IgM specificity, some of the things you might see mixed field agglutination, because remember it's an auto agglutinin, so there's still some serum in there. So if you see this mixed field, which I've shown a picture of here, that's another thing to definitely keep an eye out. Potential autoimmune disease, okay? And of course the antibody screen. In the antibody screen you always run the autocontrol, so you're going to be able to see if the patient has an autoantibody. That's going to be usually the first place where we directly test for it. If the patient has a history of pregnancies and transfusions, you have to do the antibody screen because you know that they have a risk of alloantibodies. So if they have the autoantibodies on top of it, it's going to be a problem. Okay, we have to be able to remove that autoantibody, characterize it, and also then look for alloantibodies that might be present in the patient's serum. Now, there's nothing you're going to be able to do about the autoantibody in the patient's blood as far as transfusion goes. However, we do want to try and characterize it so that we can give them units that are negative for whatever they're reacting against. Okay. And you would remove that antibody, the autoantibody, by elution. Again, if you elute out the antibody, which you can do by autoadsorption, incubate the serum with the patient's own cells to remove the autoantibody, and then spin out the cells, separate the serum, and react that serum against a panel again. Okay, but you still want to try and characterize the autoantibody, and in that case, you'd have to elute the antibody off of the cells to be able to identify its specificity. Now, it's also important to note that when you're talking about the specificity of an autoantibody, the specificity in the serum might change after you've eluted it because there's a chemical reaction that's occurring there. So, for example, in a serum, the autoantibody might, because remember, a lot of autoantibodies are directed against Rh antigens, and they might favor the anti-little e. But if you perform an eluate, it might show pan-reactivity. So it can be difficult to identify the characterization of an autoantibody. It might require send-out. Here's an example of a panel that shows, look at the patient's cells. The PEG-AHG is positive. So you have an you have a warm autoimmune situation. And then adsorption was occurred. That's what the ADS means. So adsorption was done where you've removed the autoantibody, okay? And now you're looking specifically for any alloantibodies that might be there. The evidence that there was an alloantibody was if you look during the PEG-AHG, you can see in some cases there's a different strength, okay? And that strength, I think I'm getting the right, you can see it's slightly increased in these two. Usually autoimmune responses will be across the board the same. In this case, that seems to point to the fact that there might be an allo antibody behind it. And after the autoabsorption was done, you can see that the eluate, the adsorbed serum, was then still reactive in the same cells. And that points to a pattern. If you look through the cells, it points to a pattern of anti-big E specificity of an alloantibody behind that. So you can see some of the techniques that you might need to use in order to fully screen a patient for antibodies. The mechanism of absorption is very simple. If you have an autoantibody in the serum, you incubate it with the patient's own cells. It binds to the patient's own cells. You spin then the specimen, remove the cells, and pour off the serum. It should contain, in the end, just the, as in this case, just the antibodies that are not specific, that are not reactive. And so that serum can then be tested against your panel cells for specificity. Now, in adsorption, what am I talking about here? So the procedure for adsorption. Cold autoantibodies, they don't react at 37 degrees. However, they can still interfere with testing at the AHG phase because remember, they're coating the red cell. So AHG is going to be triggered in those cases, and so you get reactions even at the AHG phase. Okay, so because you've added another reagent, the antibody remains bound but doesn't agglutinate. But at the AHG phase, you're going to enhance the agglutination, so that's what can happen. So with cold autoantibodies, you're going to have to remove those cold autoantibodies from the red cells in order to do two things: characterize the autoantibody, but also get cells that are not coated. Okay, so you can deal with this issue by doing a couple of things. Probably the best way is to omit the room temperature incubation so that the antibody does not have an opportunity to bind to the red cells. They don't become sensitized. Okay, and then you can also use a monospecific anti-IgG and not test for complement at the IAT phase so that you don't find any complement-coated cells that might be there. So those are a couple of things, a couple of procedural notes to point out in the case of cold autoagglutinins. We also have some other reagents I just want to point out. Remember RES, we talked about that before. REST, or rabbit erythrocyte stroma, helps to remove IgM antibodies, specifically those that are anti-I specific, from the red cells. Okay, it can also, however, absorb anti-B and other IgM antibodies. So you have to be aware of what you're looking for. If you really just need to remove all the IgM, then that's fine. REST is something that you can use as a reagent. For cold autoabsorption, if you're trying to remove those, you're going to do incubate at room temperature, patient cells, patient serum, and they'll be adsorbed out. Spin it out and use the adsorbed serum, which has the autoantibody removed. Warm autoabsorption, you do the same thing at warm temperatures, spin out the cells, and use the adsorbed serum against your panel cells. Okay. The key thing there is if the patient has been recently transfused, you have multiple populations of red cells. So you can't use this technique if you've got more than one population of red cell in there. You don't just have the patient's red cell, okay? And we don't want to remove an antibody that's directed against the donor red cell that they already received. We would want to be able to detect that, okay? Now, differential adsorption is when you find a red cell. So if you're suspecting, for example, an anti-Kel, if you know, or let's say an anti-D, because that's the most common. So if you have an anti-D, an anti-RH autoantibody, if you get a D positive cell, you can adsorb it with a D positive cell, and that would work as well. Okay. So you use a phenotypically specific red cell in order to separate your, to pull out your autoantibodies from the serum. And this is just going through the procedure itself. You can read here what's going on. See in step 1, you remove the serum. You got to treat the patient's red cells to remove the existing autoantibodies. Then return the patient's serum to the treated red cells and incubate, and then remove the serum to test for alloantibodies. So that's autoadsorption, okay? Differential allogenic ones, you're going to find the patient's, you're going to find different phenotyped blood cells and incubate it with those in order to remove out the antibodies that you're suspecting. Okay, it helps you to narrow down the possible autoantibodies that might be present. There are some unusual types of autoantibodies that may occur, and these can cause clinical problems because some of these unusual types of autoantibodies can coat the red cells quite strongly and can spontaneously agglutinate in vivo. Okay. In these cases, when you have an autoantibody that causes spontaneous agglutination, now you're going to have problems with your ABO and RH typing because the red cells are spontaneously agglutinating. Okay. And since these are usually warm IgM antibodies, these you can't pre-warm the blood. It's not gonna help in this particular case. Okay, so in this case, if you have a warm IgM antibody, then you need to actually treat the red cells, and we treat them with either 0.01 molar DTT to remove the IgM from the red cell, and then again spin the cells down, remove the supernatant and wash the cells, and then you have a cell population that should allow a valid ABO and RH typing as well as valid DAT results, because the DTT should only remove IgM. Okay, so remember, usually with the DAT we're looking for bound IgG. Okay. These warm IgM autoantibodies, because they cause spontaneous agglutination, this is a problem, obviously, clinically. So these do have to be treated, and there are several possible treatment possibilities for the patient. You can do plasma exchange, which will help reduce the overall IgM concentration. You can do IVIG, you can do steroids or transfusion to dilute the specimen. They aren't necessarily equally or always successful, and this particular disease can be fatal because of this constant agglutination that's occurring and this constant problem that the patient has. So making sure that these are identified and the doctor can start some kind of treatment regimen as soon as possible, but definitely steroids to reduce the overall immune response could be helpful. Now, drug-induced hemolytic anemia. These are the ones that these would be considered iatrogenic situations where it's due to treatment, some drug treatment that the patient is on. Okay, and you need to be aware of the patient history so that you can predict when this might be a situation. Okay. Now, there are drug-induced hemolytic anemia would be suggested when there's evidence of either hemolytic anemia or positive DAT, but no other reason for the reactions that are taking place. So no history of sensitization, no history of pregnancies or respiratory infection or viral infection or anything like that. However, the patient does have a history of taking a recent history of taking maybe high-dose antibiotics or other drugs that are indicated, and we'll get into those. So this is very rare, only about 1 in a million cases. So all of the other causes of hemolytic anemia have to be ruled out first. Okay. Now the mechanism, pardon me, if you look at the mechanism where we see the reactions observed with drug-induced positive DATs. What do you find on the red cells? Well, and what does the serum and the elute react with? If it's an immune complex situation, usually you'll have C3 complement as well as an occasional antibody binding the red cells. And the serum and the elute will react with cells only if the serum was incubated with the drug prior to testing. Okay, routine testing with red cells is negative. You can do drug adsorption, where if the drug is adsorbed onto the red cell. In those cases, you might see an antibody bound to the red cell. And so, again, how do we know that it's drug adsorption, that the drug has been adsorbed onto the red cells? Well, in this case, if you test with routine red cells, they're going to be negative. The cells actually would have to be coated with the drug or incubated with the drug prior to the test. If it's not a drug-induced thing, all your normal red cells will react with the specimen. Okay, so that's drug independent. That's what we've talked about before. And then there are certain cases where the drugs can modify various components of the red cell. In this case, again, you're not going to really test them. The mechanism is non-immunologic. In this case, it's a protein issue. So in this case, you can have any type of antibody and complement on the red cell because the membrane has been modified, so it technically has become a little bit foreign. Okay, so you're not going to find those foreign-looking cells in your reagent pool. Okay, so there's no way to test for membrane modification, but we know that it is a mechanism of drug-induced hemolytic anemia. Now, what are the drugs that cause these things? So, for example, in the immune complex mechanism, where the drug sensitizes B cells, causing it to produce antibodies, and then so that occurred in an original exposure to the drug, and then the next time you're exposed to the drug, the antibodies combine with the drug, and you develop these immune complexes. So the drugs that are associated with that are shown: quinidine and phenacetin. I don't know how to say that. These drugs, so the patient has had them, in one episode, and then the next time they take the drug, an antibody response which was directed against the drug, which is technically foreign, but they developed an antibody response against it. An immune complex is created, and as that immune complex builds up, it can cause complement to bind to, it can trigger a complement cascade, which can then obviously interfere with the red cell. In the drug adsorption, as I said, the drug can be adsorbed onto the surface of the red cell, and then antibody can attach to the drug. So you still had to have an antibody against the drug. And that would be most commonly associated with penicillin, streptomycin, and cephalosporins. Okay, in that case, your red cells are going to be bound with IgG. They'll generally be removed. The red cells that are coated will be removed by the reticuloendothelial system, and you'll get a positive DAT. Okay. Membrane modification, where the drug interacts with the plasma membrane and alters its appearance to the immune system. This is most commonly associated with cephalosporins, and it can cause several plasma proteins to bind to the red cell, including IgM, IgG, IgA, complement. They can all bind. Now, this is technically not immunogenic, right? It's technically, it's not really immunogenic. It's really an interaction between the proteins that are present in the blood and the drug that end up causing a positive DAT in the end, but it's really not directed against the red cell. The antibodies are not directed against the red blood cell at any point in this. And then finally, we have a particular case of methyl dopa-induced hemolytic anemia, where the patient develops an IgG against the methyl dopa or the albumin, and you can end up with a very strongly positive DAT result, and it'll have characteristics of a warm autoantibody. Okay, it doesn't usually lead to hemolytic anemia. In the majority, only a small percentage develop anything that looks like a warm autoimmune hemolytic anemia, but patients receiving 15% of your patients receiving methyl-dopa will end up with a positive DAT. Okay, so they don't necessarily develop anemia, but they will have a positive DAT, which will then interfere with your results in the blood bank.